I'm David Cutler. I'm professor of economics at Harvard University. I recently wrote a perspective in the New England Journal of Medicine on the impacts, likely trends in healthcare spending. In the past several decades, healthcare costs have increased quite rapidly compared to GDP. And so essentially all forecasts, including public as well as private sector forecasts, suggest that medical costs will continue to increase as a share of GDP and extremely rapidly. So for example, we now spend about 17% of GDP on healthcare, and most estimates are that will go to about 30 to 35% by the middle of the century. Yeah, essentially all forecasts of healthcare spending look to the past initially. And in the past, healthcare spending has increased quite rapidly relative to GDP. And so they assume that that trend will continue, taking healthcare from something like 17% of the economy to a third of the economy by the middle of the century. The most important component driving medical care spending over time has been technological change in what we can do. So being able to do more things for more people in more different settings. And what everyone does when they do forecasts is they project what the rate of technology will be in terms of how it affects spending. Our best guide to that is the past. And so what various researchers have done is they've sort of filtered through the past and said what share of the cost increases are a result of technological change, roughly about a half of cost increases. And therefore, let's assume that approximately about a half of the past rate of cost increase will continue into the future, possibly with a little bit of slowing down in the farther out future associated with a couple of things. But to a first approximation, kind of assume that if the technological component has been 1% a year above GDP growth, let's assume that healthcare continues to be about 1% a year above GDP growth. As we were mentioning, the biggest item in spending growth is technological change. And one of the interesting things is that the pipelines for technology are somewhat drier than they used to be. And so you take an example of pharmaceutical spending, which in the 90s was increasing an enormous amount. And companies were scared and governments were scared about new drugs like Lipitor that became a $10 to $15 billion a year drug. The interesting thing about Lipitor and the class of drugs like that is there hasn't been a Lipitor since Lipitor. That is about 10 to 15 years. There hasn't been this astronomical blockbuster like that. And we have a pretty good sense of what's going to happen in the next 3 to 5 years because we can see what's coming off patent, Lipitor will be, and what new things are immediately in the pipeline. The interesting thing that companies like IMS Health find is that the pipeline looks relatively dry compared to the past, and there are a lot of drugs, like Lipitor, that are coming off patent in the next couple of years. And so the net effect is that pharmaceutical spending is likely to be very low over the next couple of years, if not actually even declining relative to GDP, but let's say very, very small or no increases nominally in drug spending. Imaging is a large and growing share of spending. It's, the exact numbers are a little bit hard to figure out because some of it's buried within, for example, hospital costs. But physician and clinic services, which is about 30% of medical care, and imaging would be a fairly big part of that. The rate of imaging in, for example, Medicare has tripled just in the past decade. And any time that something rises that rapidly, you start to see payers focus on it. Go back to pharmaceuticals. The payers focused intensely on pharmaceutical costs in the 1990s. Amongst the things they did for Lipitor, just to come back to that example, they encouraged people to split pills. They encouraged people to switch into generics when generics became available a couple of years ago. They put it on a higher tier of the formulary to make sure that people really needed it. So there were a lot of steps that were taken to reduce the amount of spending. The same is true with mental health care, which was rising before medications. Firms got on the sort of mental health care management bandwagon. They got people out of psychotherapy and into medications. They really clamped down on behavioral health care. They managed to figure out how to reduce spending quite a lot. I think we're likely to see the same thing in imaging. Imaging is growing rapidly. You already see companies and insurance plans starting to set up radiology benefit managers who will do some assessment of when the images are needed or not. I'm not saying they will get it right. I'm just saying that that's going to very clearly be a target area, and you're going to see a lot of people focusing on it because that's where an enormous part of the growth in the past few years has been. If you think about technology, the way that technology diffused is it always started off in people who very clearly needed it. So think about stenting for people with a heart attack. They're too weak to undergo bypass surgery. We wanted something less invasive, so you give it to those people immediately. And then technology spreads into people who may or may not need it as much. Same thing with chemotherapy. It's sort of initially given to some folks, and then, well, we'll try it on other folks, and we'll see what happens. It's a lot of the sort of blockbuster nature of technologies are the application of those technologies to people in whom it was not initially developed, and for whom we don't necessarily know whether that's the right therapy or not. And we only learn many years later, after it's become so common, whether it was worth it or not. The thing about personalized medicine that promises to be a bit different is that we'll hopefully be able to learn in advance which kinds of people are likely to benefit from a therapy and which will not. So take a very clear example, which is Herceptin, which works on women with a certain type of breast cancer and doesn't work on other kinds of women. Well, in the old days, we would have just applied it to all women because we didn't know who it would work for, and the studies would have shown it was fairly effective and so on. And now we have a way of genetically typing women so we know which kind of women will benefit from Herceptin, which kind will not. We'll cut the number of people who receive the medication, which, unless prices rise an enormous amount, will lead to less spending than in the days where we would have just done it for everybody. Electronic medical records are really part of a foundation to really cut costs. It's kind of like having a good structure of a building. It doesn't make the building itself look great, but it sure is important. And so if you have the right information, you can do all sorts of things. One thing you can do is get rid of people whose job it is to document things, or have people whose job it is to document things be able to care for patients because you're doing the documenting electronically. Another thing you can do is learn what works. Again, in these examples about medications, we'll be able to learn much better which medications work and which don't work because of information technology. So it promises to sort of provide the foundation on which we can really erect a healthcare system that's higher value and lower spending, not by itself, but in combination with a variety of other things. The thing that we know is that just by itself, sticking a computer on the desk of a doctor doesn't do anything to reduce spending. It has to be used the right way. So you have to have the information there, and most of the times now the information is not there. You have to be able to give the doctor what we know in aggregate about good treatments and not good treatments, and you have to be able to work with the patients. It is an absolutely correct statement that if you put a computer on the desk of a doctor and don't hook it up to anything, you're unlikely to get any good benefits from it.